This presentation will review disorders of the integument, and although not fully comprehensive, it will cover the areas that will be tested upon. To review the structure and function, you can look at structures on this title page, but also review functions in the textbook. We are going to go over primary skin lesions, and many of these you've already looked at in your health assessment book, so it should be a review. Macule versus a patch really has to do with the diameter. Macules are less than a centimeter in diameter, while patches are greater than a centimeter in diameter. They're flat, circumcised areas that change in the color of the skin. A perfect example of a macule would be a freckle or a flat mole nevi. Petechiae can also be considered a macule as long as it's under a centimeter in diameter, but it has a vascular origin. You might see macular rashes in measles and scarlet fever. Patches are also flat, they're not palpable, but they're more irregular shaped, and they're macules that are 1 centimeter or more. For example, you can see this picture of vitiligo, but port wine stains, Mongolian spots, and cafe au lait spots are also examples. You can find great pictures in your health assessment book and also refer back to your pathophysiology book for more examples. Papule versus a plaque. A papule is an elevated, firm, circumcised area less than 1 centimeter in diameter. For instance, a wart or a mole that you can feel the elevation of. An insect bite would also be called a papular. If you break out because you have insect bites throughout an area of your body, that might be called a papular rash. However, a plaque is also elevated. It's firm, but it's rough and it has a flat top surface. These plaques are going to be greater than a centimeter in diameter. So patients with psoriasis or seborrheic and actinic keratosis would be examples of plaque or plaques. So the difference here again is a papule is less than a centimeter and a plaque is greater than a centimeter. Both elevated and both firm. A wheal is an elevated, irregular shaped area of cutaneous edema. It's usually solid and transient, meaning it comes in, it might go, typically with an allergic reaction. They're variable diameter size wheals. If you get an insect bite and you're allergic, you might have a wheal. Urticaria or hives are an also example of wheals. The difference between a nodule and a tumor is also the size. Nodules are elevated, firm, circumcised lesions that are deeper in the dermis than a papule. They are 1 to 2 centimeters in diameter. Lipomas, which are collections of fat within the dermis, are considered a nodule. However, tumors are greater than 2 centimeters in diameter. They're also elevated, they're solid lesions, and they could be clearly demarcated deeper in the dermis. However, again, it's greater than 2 centimeters. So any type of neoplasms, but they can also be benign tumors. We also have lipomas that are greater than 2 centimeters. Neurofibromas and hemangiomas can also be considered a tumor. So we typically will use the term tumor and automatically think malignancy or cancer, but that word tumor does not necessarily mean it is cancerous. Vesicle versus a bulla. A vesicle is an elevated, circumcised, superficial lesion that is less than a centimeter in diameter. It is not extending into the dermis layer, and it's usually filled with just serous fluid. So think about in terms of shingles or herpes simplex virus or chickenpox or varicella, that would be called a vesicle or a vesicular type rash, and sometimes it's called vesicular. whereas a bulla is 1 centimeter in diameter or more. Also vesicle, but larger. And examples would be blisters that are larger than a centimeter. The term vesicle or vesicula in Latin means little bladder, and bulla means bubble. We're still talking about primary skin lesions, pustules versus a cyst. A pustule is elevated, superficial lesion. It's very similar to a vesicle, however, instead of serous fluid, it's filled with purulent fluid. Pus is made of leukocytes and a thin fluid called liquor purus, and this is what is typically found in a pustule. Versus a cyst is also elevated, it's circumscribed, and it's encapsulated. So it goes into the dermis and the subcutaneous layer. It's filled with liquid, or it could be a semi-solid type material. So think of cystic acne, sebaceous cysts. Those would be examples of a cyst. Telangiectasia, they are fine, less than 1 millimeter, irregular red lines produced by capillary dilation. And typically with patients with acne rosacea, which is on your face, you will see these type of primary lesions. Also venous hypertension, spider veins in the legs. This is also a type or an example of this type of lesion. And you can see that, and not only with the lesions and the irregular red lines, you may see generalized erythema surrounding the lesion. Now we're moving on to secondary skin lesions. Scale versus lichenification. A scale is heaped up keratinized cells, usually flaky and irregularly shaped. It could be thick or thin. Scales can be dry or oily, and they can vary in the different sizes. So think about someone with seborrheic dermatitis, and this will happen following scarlet fever. You get a lot of skin sloughing off. Also, in drug reactions, you will get scales as well, and just generally having dry skin. You can chart that type of dryness as being scales. Lichenifications, these are rough, thickened epidermal layer lesions, and they're secondary to persistent rubbing, itching, or skin irritation. And often it involves flexor surfaces of the extremities, like the inside of your antecubital space. And with chronic dermatitis and constant, itching and rubbing on the area, you can have a lichenified lesion. Keloids and scars are also secondary skin lesions, and they are, the keloid itself is an irregular shaped, elevated, progressively enlarging scar, and it grows beyond the borders and the boundaries of the wound itself, and it has to do with excessive collagen formation during the healing process. The darker your skin is, the more likely you are to have keloid formation. We will have keloid formation on our patients after surgery sometimes, whereas just a regular scar is thin, but it can also vary to thick fibrous tissues that are just trying to replace the normal skin following some type of injury or laceration to the dermal area only. And you'll see this in surgical incisions, but also healing wounds. I'm sure everybody has at least one scar on their body. And excoriation is also a secondary skin lesion, and this has to do when there's actual loss of the epidermal layer. Usually it's linear and hollowed out, and you may see even some crusted areas. So if you have any type of abrasion or a scratch, and this is an example too of scabies, could also be a form of excoriation. Versus a fissure is any type of linear crack or break from the epidermal layer to even the dermal layer, and it could be moist or dry. So think of someone that has athlete's foot or really bad calluses or cracks in their feet. Those are fissures. You can also see them in the corner of the mouth, any cracks in the anal fissures, or also in severe dermatitis, you will see fissures as well. So again, it's going from the epidermal and to the dermal layer, whereas excoriations are only in the epidermis. Erosions and ulcers. So erosions are a loss of the epidermis and partial loss of the epidermis, and it's a depressed lesion. It's usually moist, and it follows a rupture of a vesicle or a bulla, or if you've had any type of chemical type injury to your skin. An ulcer is a loss of epidermal layer too, but it can go all the way to the dermis. It's usually more concave, and it can vary in different sizes. Think of venous stasis ulcers and pressure ulcers. Atrophy happens when we age, and it's the thinning of the skin surface and the loss of skin markings. However, another type of atrophy or atrophic scar could be striae that can happen with pregnancy or just the stretching of her skin, and more layman's term would be called a stretch mark. These are special skin lesions. We have comedones, which we usually see in acne, and it's a plug of sebaceous and keratin type material trapped in a hair follicle, or somewhere on your face. Open comedones have dilated orifices, and we would call blackheads open comedones, where whiteheads would be an example of a closed comedone and has a more narrow opening. We use the term burrow when we're talking about any type of narrow, raised, irregular channel that's caused by a parasite. And please know the difference between petechiae and purpura. And the difference here is the size. When I think of petechiae, it has an eye in it. They dot the eye. They're always little pinpoint dots less than half a centimeter in diameter, versus a purpura would be any circumscribed area of blood that's greater than 0.5 centimeters in diameter. So they are vascular in nature, petechiae and purpura. Pressure ulcers are a type of pressure injury that develop over primarily our bony prominences. So think about like our heels, our sacrum, the greater trochanter. These are areas where most pressure ulcers can be found. And when there's continuous pressure or shearing of those bony prominences, our skin starts to distort, or that surface will start to distort the capillaries and include the blood flow. If we occlude blood flow, we're also occluding oxygen supply. And you can see there's classification of the stages and grades of pressure ulcers. Stage 1 is non-blanchable erythema of intact skin. Darkly pigmented skin, you might not even see the visible blanching, but it would still be a stage 1 pressure ulcer. In a stage 2 pressure ulcer, this is a partial thickness skin loss with exposed dermis, and you might see erosion, ruptured, blistered, or it could even be intact, but it involves the epidermis or the dermis, and you might see a shallow open ulcer with a partial thickness or a stage 2. You might see red, pink wound beds without any sloughing, but there also can be deeper tissues, but just not visible. In a stage 3 full thickness pressure ulcer, there is skin loss involving the damage. You might see necrosis of the subcutaneous tissue, and it could even extend to, but not always, through the fascia, and it doesn't go through the fascia though. Adipose tissue might be visible, and you might see granulation tissue forming, and rolled round edges are often present in a stage 3 full thickness. In a stage 4 full thickness, skin and tissue loss is going to be seen with exposure of now muscle, bone, and all the supporting structures under our skin, like our tendons and our joint capsules. And this can also include undermining and tunneling of that skin, and it forms this sinus tract. There are stage 5 and stage 6 pressure injuries, but we don't usually talk about it in terms of stages. However, these are unstageable, but like a stage 5 would be an example of a full thickness skin with tissue loss, and you might see a sloughing and eschar. And deep tissue pressure ulcers are like stage 6 with persistent non-blanchable skin, and they actually look very purple and maroon, burgundy type color with epidural separation. But most of the time when we talk about pressure ulcers and when we see pressure ulcers in the hospital, they're usually just staged from 1 to 4. So if you want more information about 5 and 6, please go to your textbook and read just a little bit more on that. Overall, there's going to be some superficial damage resulting in the layer of the dead skin at some point if we don't try to correct it or take the pressure off that bony prominence. So there's other type of clinical manifestations as well of different skin disorders. We've talked about this terminology in the past, so, rubor versus tumor, calor, dolor, and paresthesia. We're going to talk about pruritus a little bit. This is, itchiness, but understanding more why this occurs. And typically with patients with eczema, psoriasis, and even if you have lice, you can start to have a lot of pruritus. Patients with chronic renal failure or cirrhosis, which means just dry skin, they can also have lots of pruritus. If you have iron deficiency or neuropathies, malignancies, these can also cause itchiness, and even the use of opioid type drugs. So in this process of pruritus, which is the most common skin symptom actually of primary skin disorders, you are getting that itch because of the small unmyelinated type C nerve fibers transmitting that itch sensation, and it goes through specific spinal pathways that carry that itch sensation through the spinal cord and then up to your brain. And these nerve fibers may interact with even the dermal eosinophils, lymphocytes, and mast cells. So your CNS mechanism should be able to modulate this itching, which is less perceptible when your mind is being distracted or there's other stimuli as well. And so the central nervous system can influence this sensation to itch by, basically taking your mind off things. But that ability to do that is still unclear. We don't really know the pathophys on exactly why this happens. We could even use the term neuropathic itch, which means that there's some type of stimuli related to the afferent pathway. And psychogenic itch is also associated with psychological disorders. So think about patients with depression or OCD, obsessive compulsive disorder. They might have this type of psychogenic itch. Going back to the neuropathic itch, an example of that would be like a post-hermetic neuropathy, and sometimes after shingles, even when the lesion is gone, you still get that sensation to itch. Persistent scratching due to chronic itching can actually result in infection and scarring, and it's very unpleasant to have that sensation all the time, and most people relieve that sensation by scratching, but it does leave trauma to the body. Allergic contact dermatitis is a type of inflammatory disorder, and the most common inflammatory disorders are actually dermatitis and eczema. And these are described as inflammatory disorders because you get an inflammatory response. And sometimes we use that term dermatitis and eczema interchangeably. But when you have an eczematic disorder, we usually will have pruritus, so itchiness, and there's going to be lesions with very indistinct borders, and you might see some epidermal changes. It might appear to be erythema. You might have papules or scales in some people. Sometimes it's very itchy and sometimes not very itchy. You might see edema in some people, and some people you don't have edema. Sometimes you might see some discharge and serous fluid or crusting. It kind of ranges, even thickening of the skin or leathery type skin. All of these could be within the realm of atopic dermatitis. But with contact dermatitis, this is a form of T cell mediated or a delayed hypersensitivity type 4 response. And this is important and distinguishable. For instance, poison ivy would be a type of contact dermatitis. Some of us might be more sensitive to household detergents and skin products, and that would be a type of contact dermatitis as well. So haptens or allergens, they come in contact with our skin and they bind to carrier proteins that will sensitize that antigen. Well, the APCs or antigen presenting cells will try to process the antigen and present it to the T cell. But when this happens, it becomes sensitized to the antigen. Hypersensitivity reactions, like type 1 reactions, are associated more with the IgE antibody. And, overall, you're going to see, again, erythema, swelling, pruritus, and sometimes you might even see vascular lesions. The pattern of distribution provides clues to us to what the source of antigen was. So think about if someone has a lesion that goes around their wrist. That gives us a clue. Maybe it was a bracelet or their wristwatch or their iWatch, or Apple Watch, excuse me. Chronic atopic dermatitis can also result in lichenification or even fissuring or thickening and scaling of the skin because you're constantly irritating that area. Atopic dermatitis, eczema, is more common in infancy and childhood than it is in adults, but some adults do have eczema throughout their lifetime. It's an inflammatory disorder as well, and we don't really know the cause, but 80% of individuals have some type of family history or personal history of asthma, allergic rhinitis, and even food allergies. And so whenever I get a patient that has asthma, I also look for eczematic scars and atopic dermatitis as well. And like I said, people will outgrow it, but not everybody. And it can be in all different areas of your body. You can see here it's in the arm folds or the antecubital areas. That's a very common place behind the head, like behind ears and the hairline. That's also a very common place. We know that there's certain triggers that can make the condition worse, like hot or cold temperatures, stress. There's certain fabrics. Detergents can also cause eczematic flare-up as well. So overall, with these type of atopic dermatitis processes, the clinical manifestations are going to be severe pruritus to where most patients can't stop itching even though they know it's going to make it worse. And you're going to see this redness, edema, and scaling. For our younger patients, it's usually found on their scalp, their trunk, their arms, legs, and even on their face. And older patients will present more in that antecubital space, on their neck, their hands, and their feet. However, I have a couple children and my couple other family members that have eczema, and young and old, they kind of present all in the same areas. Your lab findings that would give you clues that they are suffering from eczema and not other types of like allergic dermatitis would be an elevated eosinophil count, elevated IgE or interleukin 4 as well. And you can do positive allergen skin testing to also confirm eczema or atopic dermatitis. Acne vulgaris, this is the most common skin disease, and it affects 85% or more of the population between the ages of 12 and 25 years old. And it develops in the pilosebaceous follicles. So this is the hair follicles that have sebaceous, oily, glands, and located primarily on the face, but you can also find it in the upper parts of the chest and the back. During puberty, these sebaceous glands start to enlarge because they're stimulated by the androgen hormone. In Latin, vulgaris means common people. So this is very common to people to have this type of acne. You will see in patients with acne vulgaris a hyperkeratinization in the follicular glands, and it could be normal desquamation processes that help to interrupt this excess keratin, and it causes the dead skin cells to bind together and it blocks the area, and so it's blocking and causing comedones. So there's excessive sebum in those areas in the sebaceous glands, and it's also in conjunction with the colonization of Cutibacterium acnes, and it used to be called Propionibacterium acnes. The C. acnes it's this inflammatory response secondary to the produced C. acnes. These are gram-positive rods, and as they invade this area, and then we have this hyperkeratinization and the sebum builds up, things get blocked, and so we form these comedones. And the comedones are anywhere where you have a hair follicle and it becomes blocked with keratin and oil. And again, if it's open, it's called a blackhead, and if it's covered with skin, then it's a whitehead. Cystic acne is caused by follicular wall rupture, and then the comedone becomes closed, and nodules are going to develop, and so that inflammation gets even deeper and deeper, and so you'll see cysts and scars with severe acne. There's also something called inverse acne, and hidradenitis suppurativa. This is chronic inflammatory recurring scarring, and you see it again. It's also the pilosebaceous follicular ducts, but usually it's where you have skin folds, and there's also the hair follicles. And now, not only are we talking about the sebaceous glands, but we're also talking about the African sweat glands. So think about like your armpits or the axillary areas, inguinal areas, genital areas, buttocks, and the perineal areas. You might see this type of skin lesions or skin disease. And it is, again, chronic and inflammatory, and many people will have scarring from it. The pathogenesis of the disease is pretty complex. It's a combination of not only genetics, but also hormonal, immune factors, and also environmental factors. It's been studied, and it shows that smoking could be one of the significant factors, because nicotine activates the keratinocytes, the fibroblasts, and the immunocytes. And this could set off this response for inverse acne. We're going to talk about drug reactions, and the most often seen drug reactions that we're going to see are rashes. And not all of them are allergic reactions, but we have to look and determine, is it an immediate reaction or is it delayed reaction? Sometimes you'll take a drug and you might not have an allergy or rash until 2 days later, and sometimes you get it right away. And basically, if this happens, you want to discontinue the drug. You might have to provide your patient with antihistamines to bring down the inflammation, and corticosteroids can also be given if it is severe. If you have a true drug allergy, let's say to opioids, which is kind of rare, it has been studied, and typically we've seen that they are IgE or T cell mediated. Erythema multiforme is a T cell mediated immune reaction to drugs, or a reaction to a microorganism even. And what you're going to see are these target lesions or bullseye lesions, and they target the small vessels in the skin and the mucosa. There's two severe variants that we'll talk about, Stevens-Johnson's syndrome and also 10, which is toxic epidermal necrolysis. And 10 is the most severe. You can see with erythema multiforme, which is more minor, and this is the picture that you're seeing there. You see the central clearing, and it does really look like a target or bullseye. With Stevens-Johnson's syndrome and also the toxic epidermal necrolysis, it's the same disease, it's just the continuum of the symptoms itself. So 10 is more severe than Stevens-Johnson syndrome. But distinct from the previous erythema multiforme. And so usually they are associated with severe cutaneous drug reactions and very extensive keratinocyte cell death. And you'll see a bullous epidermal attachment or mucositis, and maybe even other organ involvement with these syndromes. With Stevens-Johnson's, usually you'll see it only less than 10% of your body surface area and tends to be milder than a toxic epidermal necrolysis or 10, which usually involves over 30% of the body surface area. Lesions usually appear within 3 to 10 days after the drug introduction, so it's a more delayed reaction, and it has to do with cytotoxic T lymphocytes in the human lymphocyte antigen or HLA, and these mediate the immune mechanisms related to the drug reaction itself. So what you might notice in your patient prior to having a severe 10 reaction or the toxic epidermal necrolysis reaction is fever, headache, malaise, sore throat, and even cough. And usually about 30% of cases, you're going to see those more prodromal symptoms before the patient actually breaks out in a full Stevens-Johnson's or toxic epidermal necrolysis reaction. It is a dermatological emergency, and treatment is individualized, and really in most cases it requires being cared for in the burn unit, and the management is primarily replacing fluid and electrolytes and making sure that the mucous membranes are carefully managed and that we are preventing infection and providing comfort. With cellulitis, this is an infection of the dermal layer of the skin and the subcutaneous tissue. It's usually following a streptococcus type infection, most commonly MRSA or group B streptococci. And it can be extensive following a skin wound or an ulcer, or maybe even from furnicles and carbuncles as well, that can set off cellulitis. It's associated with chronic venous insufficiency, so we've talked about already venous stasis type ulcers and cellulitis. And the major risk factors are diabetes. You might see edema, peripheral vascular disease, if you've had any type of a fungal infection, insect bites, or immune suppression. The infected area is going to appear erythematous, very warm, swollen, very painful, and it can actually extend to your lymph nodes and into the bloodstream. So your initial treatment really needs to be fighting this bacteria with an antibiotic that is going to both cover streptococci and staphylococci. And corticosteroids are also typically used to help manage the inflammation. If you don't treat the cellulitis, you can break out into a systemic infection. You might see abscess formation, and you might even see purulent exudate, but not always the case. Impetigo is another superficial infection of the skin, but this is with the coagulase positive Staph aureus, or you might see it in an alpha hemolytic streptococci, like a strep pyogenes, which is less common. You'll see bullae and also vesicles, but the hallmark of this skin lesion is honey crusted or honey colored areas and vesicles that have ruptured. Usually the more hot it is or the more humid environments will trigger impetigo. You do see it a lot in children. It's more common than seeing it in adults. Lyme disease is a multi-system inflammatory disorder, and it is triggered by a spirochete called Borrelia burgdorferi, and it's transmitted by tick bites. It's the most frequently reported vector-borne type illness, and usually among children. It's very difficult to culture this because it escapes immune defense through antigen variation, if you remember that term, antigenic variation, and it blocks the complemented mediated killing. And so it impedes this antimicrobial peptide and leukocyte chemotasis. And so by doing that, it's able to hide inside the tissue and spreads throughout the other tissues by entering the capillary beds and permeating through. What you typically will see is symptoms in 3 different stages. First, it's very localized within 3 days to about 30 or 32 days, and you'll see that bullseye rash or the erythema migrans, raised and erythematous, and you might see flu-like symptoms like fatigue, fever, chills, body aches, and headache. Then you will enter the disseminated infection, and this happens between days and weeks at a time, and it's secondary to seeing that erythema migrans type bullseye rash. You might have meningeal irritation and myalgias and arthralgias. And if you haven't been able to remove that tick by the stage, and you have late persistent infection, it can continue for years. And so patients will have Lyme disease, and their chronic symptoms are going to be arthritis, encephalopathy. They'll even start to have polyneuropathy. It becomes very painful. Sometimes even facial palsy. It's usually unilateral. And Lyme disease can eventually lead to heart failure as well. They do serological testing to confirm the diagnosis. And although there is a delay in the antibody response, your test can actually be negative during the first 3 weeks after an infection. We try to treat with antibiotics as soon as we find out. Um, and the longer treatment is going to be reserved for those patients that actually do have the more neurologic disease and arthritis, so those that are in that late persistent phase. Now we're moving into the last 2 slides talking about the skin cancers of the epidermis. And so non-melanoma skin cancer, this is the basal cell and the squamous cell. And so basal cell carcinoma, or BCC, it's the most common cancer in the world and the most common skin cancer, obviously, by default. And the risk factors are chronic ultraviolet light exposure, radiation. If you have fair skin or you've had a lot of radiation therapy, you're probably going to be more prone for basal cell carcinoma. And if you're older, then you're also going to be more at risk for basal cell carcinoma. And it has numerous subtypes, which you don't really have to know for this class. What you do want to know is that metastasis is rare, it's slow growing. It does often ulcerate, which you can kind of see in some of these examples here, and eventually it will develop crusts. And when you feel it, it is pretty firm. And so some might be very nodular and some are pigmented, and sometimes you just get a combination of both. The tumors usually grow upward and laterally or downward to the dermal area or the dermal epidermal junction type areas. And as the lesion grows, that's what causes this ulceration and crusting. And again, it becomes very firm. With cutaneous squamous cell carcinoma, or SCC, this is a tumor of the epidermal layer with uncontrolled growth of the keratinocytes, and it's the second most common human cancer. And so we have the in situ version, or the more invasive version, which is also called Bowen disease, and again caused by ultraviolet radiation exposure. And you might have risk factors like genetic predisposition and radiation exposure as well. Immunosuppression is another reason, and also fair colored skin. Most of the time, it's the head and neck areas that are going to present with squamous cell carcinoma about 75% of the time, but also your hands are about 15% of the places where you might see a squamous cell carcinoma. You will see in patients with squamous cell carcinomas very scaly patches, open sores, crusted nodules, or wart-like bumps. And so they don't always look the same, and sometimes it's a combination of those types of presentation. It can spread to your tissues, bones, and the lymph nodes in those areas as well. Cutaneous melanoma is now a malignant tumor versus the other two that were non-malignant, and it originates from the transformation of the melanocyte itself, or the cells that synthesize the pigment, melanin, and gives you your color. And melanoma is the most serious type of skin cancer, with an estimated nearly 90,000 new cases and about 10,000 deaths in the US per year. Non-cutaneous melanoma is pretty rare, but it's the most common place is in the uvea of the eye, and also found in the mucous membranes. There's uncertainty how much of an increase really has to do with or can be detected, and potentially we try to look for these type of melanomas, but they can be overdiagnosed because we're kind of looking all the time. But actually discovering melanoma at an early stage will help increase the 5-year survival. So there is kind of mixed feelings about this at the time. The major risk factors are family history, if you are exposed to ultraviolet light exposure, could be solar but also artificial light exposure. So that's why there's been talk about in nail salons ultraviolet lights that you put your hand in to help dry the polish. It isn't actually a form of artificial UV light that could potentially cause melanoma. It does metastasize widely to other parts of the body. It is the most serious of the skin cancers. Kaposi sarcoma is also a type of skin cancer, and typically you're going to see more purplish brown lesions, and it's pretty painful. And you'll see vascular malignancy. Because it's a vascular malignancy, that's what's giving it that more purplish brownish tone. And most patients that have Kaposi sarcoma have some type of immunodeficiency that is pretty common with Kaposi sarcoma.